Hello, hi, good evening, friends. So, welcome to the November INI recall. Now, first of all, today we have got a big important news that November, like the NEET 2024 exam date is announced. It is on 9th of February. It is on 9th of February. So this is the high time. So these 3 months are very crucial. These 3 months are very crucial for you to revise. Just finish all your revision in these 3 months and you will be done with your exams. Now for the students, those who have not started with the preparations, I would suggest that crash course and test and discussion. Start with the crash course and test and discussion. Okay, this will suffice your majority of the portion. Okay, so don't start reading from the textbook. Do crash course and test and discussion. It will suffice majority of your subjects and the topic. So now coming to the November INI recall. Now, this November INI question, I would suggest that especially with respect to oral pathology, the questions, they were of moderate level. They were not very easy, they were not very tough. But they were direct pick questions from the past May paper. I guess there were 2 to 3 questions. They were directly picked from the past May paper. But as usual, INI paper always gave us a lot of surprises. So there were few questions which were slightly out of the topic, but it's okay. So the first question was the most common site in the oral cavity for myiasis to occur. Now there were 3 back-to-back questions from myiasis. Now I will tell the answer later, okay, but I would first tell you what were the other questions with respect to myiasis. The other question was, which of these countries has the highest maximum prevalence for the oral myiasis? And the third question was, which of these are not characteristic feature of oral myiasis? Now, oral myiasis, it occurs as a result of larva or the parasite which come to the infected area or patients who are not maintaining the proper oral hygiene. So, all these questions were direct picked from one of the article which I will quote right now. Now, see, oral myiasis. The most affected countries which were seen with respect to oral myiasis was India, that is 41%. And the most prevalent site is gingiva with 29%. So the answer for the first question is gingiva. Now there are many studies which suggest that palate is also a site for oral myiasis, but even in Schaefer's, the first most prevalent site of the oral myiasis given is gingiva. Now, which of these countries has maximum prevalence for oral myiasis? It is India. Now, in the textbook, I know that it is written that subtropical region. It occurs most commonly in the subtropical region. So, India and Brazil, they both are subtropical region, but highest seen in India. Now, which of these are not characteristic feature of oral myiasis? Now, the most common site for oral myiasis is gingiva. So gingiva, what is the most common effect which we see if we don't maintain the poor oral hygiene? If we have poor oral hygiene, the gingiva is the first site to be get affected. So not characteristic feature of oral myiasis. Poor oral hygiene is there. If a patient is immunocompromised, open wound, obviously if the wound is open, it will have a more tendency to get oral myiasis. So proclination of lower anteriors is the answer. Now, coming to the oral myiasis. Now, these are formed from the larva which are called as maggots, most commonly seen in subtropical region and associated with poor oral hygiene. Now, it is a rare condition but most commonly seen in gingiva. Our first priority will be given to gingiva, palate, second priority, and then the extracted wounds. Okay, so this was the question. Now, which of these conditions will not show a positive Nikolsky sign? So this was the question which I had discussed in the May INI paper. And many times this question is discussed in the live class. Okay, so this is a very direct question. The answer is bullous pemphigoid. So what is Nikolsky sign? Okay, what is Nikolsky sign? When we apply a lateral pressure surrounding the vesicle or the bulla, a new vesicle or the bulla appears. So this is Nikolsky's sign. So in pemphigus vulgaris, what do we see? We see suprabasilar split. Okay, suprabasilar split is seen, and when we see on direct immunofluorescent, we see chicken wire pattern. So this is a classical chicken wire pattern which is seen by pemphigus vulgaris. Now, which of these conditions show clefts in the suprabasilar region? Again, the answer is, this was an image based question. So suprabasilar region में cleft, we have discussed this. Suprabasilar region में cleft कौन सा देखते हैं? We see pemphigus vulgaris. While subbasilar split is seen in bullous pemphigoid. Subbasilar split is seen in bullous pemphigoid. Now, a patient comes with a complaint of oral sores. He gives a history of fluid-filled vesicle blisters that burst a few days back. Histopathological examination shows Lipschitz bodies and ballooning degeneration. So based on this, we will mark our option. If Lipschitz bodies and ballooning degeneration is seen, it is seen in, most commonly it is seen in herpes simplex virus. Okay, herpes simplex virus. Now see, this is a herpes simplex virus with the Lipschitz bodies. Okay, now what are these? These are type A inclusion bodies. These are intranuclear inclusion bodies. Now see, in rabies, what do we see? We see Negri bodies, while in cytomegalovirus, we see owl's eye appearance as a inclusion bodies, which is basically basophilic. Now what happens here is, what are Lipschitz bodies? Basically, these are eosinophilic. Now Lipschitz bodies, these are eosinophilic and these are present within the nucleus of the cell. Now if I say this is the nucleus, this is the cell, this is the nucleus, and Lipschitz bodies are present within the nucleus. Now what they will do? They will displace the nucleolus. They will displace the nucleolus and the space will be seen as perivascular halo. A halo-like space will be seen because of the pushing of the nucleolus within the nucleus. Okay, so these are Lipschitz bodies. So displacement produces peri-inclusion halo. Now when we see on the Zank sphere, multinucleated giant cells are seen. Now there's one more very important point with respect to herpes simplex virus, that it is isolated when there is a low production of A globulin. When there's a low production of A globulin, then only these viruses will get isolated. Now this question. A patient coming with the burning in the oral mucosa and had a difficulty in chewing. On examination, there was an ulceroproliferative growth was seen. Then a biopsy is taken. Now, what do we see in biopsy? Show nest of the squamous epithelial cells with keratin pulse, epithelial dysplasia and increased mitotic figure. So, with this, the options, the answer is very clear that there is a keratin pulse, epithelial dysplasia and increased mitotic figure. So here comes to our answer is squamous cell carcinoma. While all other pathologies, we don't see keratin pulse. So keratin pulse is a characteristic feature of squamous cell carcinoma. Now, this question, I hope majority of the students, they were slightly confused between the ossifying fibroma and semimatoid ossifying fibroma. So I'll tell you what is the major difference between these two. But here the answer is semimatoid ossifying fibroma. Now, histopathologically, it is characterized by presence of spherical ossicles. Now, these are spherical ossicles which is seen. Now, these spherical ossicles, these are called as samomatoid-like bodies. Samoma-like bodies. Now here, in the fibrous stroma, the fibrous is composed of plump spindle cells. These are arranged as fascicles and whorls. And I think that this was there in the option, that these vesicles, these are arranged in whorl pattern. Whorl pattern surrounding these spherical ossicles. with intervening collagen. Now this is our semimatoid ossifying fibroma. Now what is difference between the ossifying fibroma, that here these are arranged in the form of whorls, while in ossifying fibroma it is arranged in the form of smooth contour with a thin radiating fringe of collagen fibers, whereas in semimatoid the collagenous rim is thick and irregular. So this is thick and irregular, while in ossifying fibroma it is thin and very thin radiating line of collagen fibers are seen. Okay, so here the answer is semimatoid ossifying fibroma. Now, which of these is a low grade malignancy? Okay, so with the options we can aram se rule out. Okay, so the first option if we see as acidic cell carcinoma, chalo we don't know that acidic cell carcinoma is a low grade malignancy. Adenoid cystic carcinoma, which is the second most common malignancy of the salivary gland, it is the adenoid cystic carcinoma. Pleomorphic adenoma, it is a benign tumor. Okay, so do not mark pleomorphic adenoma because they have asked it very clearly that which of these is low grade malignancy. Pleomorphic adenoma is not a low grade malignancy. Mucoepidermoid carcinoma, it is the most common salivary gland malignancy. So coming to the acidic cell carcinoma, it is the third most common. So acidic cell carcinoma, it is the third most common salivary gland malignancy. So here the answer is acidic cell carcinoma. So the third most common salivary gland neoplasm. Now what do we see here in acidic cell carcinoma? Lot of serous acinar cells are seen. So lot of serous acinar cells are seen in acidic cell carcinoma. So most commonly it is seen in parotid gland. Okay, so most common site is parotid gland. Most common site is parotid gland, while intraorally it is most commonly seen in lips and buccal mucosa. Intraorally most commonly seen in lip and buccal mucosa, but most commonly exclusively, that 80% of the time it is seen in parotid gland. Now coming to our next question, which pathology has parts of all three germ layers of the pharyngeal pouch? All three germ layers. So this is the very direct option. Okay, majority of the time we have discussed this in the live class. Here the answer is teratoma. So teratoma is derived from all three germ layers of the oral: ectoderm, endoderm and mesoderm. So these are basically the immature cells or fully formed tissues, and these are haphazardly arranged, including teeth, hair, bone and the muscles. Most teratomas, these are benign, but they can also be malignant. Now, which pathology is associated with small round cell tumor with genetic defect, that is EWSR1? So with this genetic defect, we can mark the option, that is Ewing sarcoma. So Ewing sarcoma most commonly seen in children, and in oral cavity it is most commonly associated with mandible. In oral cavity it is most commonly associated with mandible, that is 13%, but most commonly it is seen in long bone of the extremities, but in oral cavity it is most commonly seen in with respect to mandible. Now this Ewing sarcoma, it is composed of small round cells are seen. Okay, it is composed of solid round cells with little stroma. So we cannot see any stroma in this. Majority of these are round cells with large nucleus. So can we see many large blue is present, that is it has a large nucleus with hyperchromasia. Now these sarcoma cells, these are arranged in filigree pattern. So this can be your important question, that in Ewing sarcoma, the cells, sarcoma cells, these are arranged in which pattern? These are arranged in filigree pattern. So this is a potential question. Potential question. Okay. Now, there was one histopathological image which was given with respect to ghost cell. I'll show you the image. Okay, so this was the image which was given. Okay, so ghost cells, we know ghost cells किसमें देखते हैं? Okay, we see in calcifying odontogenic cyst. Okay, so can we see this round cells appearing? So these are ghost cells. Now what are these ghost cells? Okay, so other options were COT, calcifying epithelial odontogenic tumor. So COT में क्या देखते हैं? Leasy gangrenes are seen. Dentigerous OKC, we know that it is not there. So ghost cells are seen most commonly in calcifying odontogenic cysts. Now what are ghost cells? Ghost cells, they represent calcification. They represent calcification. Now why these are called as ghost cells? Because they don't have any organelles. Okay, these are just the clear cells with no organelle. That is why these are called as ghost cells. These are just the shadow of the cell. Now it is not pathogenic, with that means it is not only present in COC or DGCT, that is we know that dentinogenic ghost cell tumor, but there are other pathologies in which the ghost cells are seen. So let's just have a look on the other pathologies. It is seen in ameloblastoma associated with CNS. Ameloblastoma associated with CNS, that is called as Rathke's pouch pituitary ameloblastoma. Rathke's pouch pituitary ameloblastoma. What are the other pathologies where do we see? That is odontoma, and dentinoid odontogenic ghost cell tumor. Okay, so we see in COC dentinogenic ghost cell tumor, ameloblastoma associated with CNS, that is called as Rathke's pouch pituitary ameloblastoma and odontoma. Now, so the other question was, which was slightly confusing. Okay, so which of these cysts is most commonly associated with vital tooth? Now some of the students, they told ki ma'am, the question was which of these cysts is most commonly associated with vital tooth. Now some of the students, they told me that ma'am, it was which is the most common cyst associated with vital tooth. So there is a lot of difference in these two questions. But if you'll ask me, if the question was which of these cysts is most commonly associated with vital tooth, then I would suggest with that you should go with lateral periodontal cyst. Okay, now why I'm saying lateral periodontal cyst? It is clearly said that lateral periodontal cyst, it is associated with vital tooth. Lateral periodontal cyst, it is associated with vital tooth. But if they have asked you most common cyst, since we know that lateral periodontal cyst, it is very rare. It is not very frequent. It is slightly rare. Okay, it is slightly rare. But if they have asked you which is the most common cyst, so most common cyst after the radicular cyst, it is dentigerous cyst associated with vital tooth. So dentigerous cyst, it can be associated with vital tooth. It cannot be associated with vital tooth. It is not a hard fast move, but we know that dentigerous cyst is associated with impacted tooth. Okay, it is associated with impacted tooth. So we do not know that whether that impacted tooth is vital or non-vital. But lateral periodontal cyst, it is associated with vital tooth. But if they have mentioned that which is the most common cyst associated with vital tooth, then the answer is dentigenesis, because dentigenesis is one of the most common cysts that occurs in the oral cavity after the radicular cyst. So radicular cyst, it is associated with non-vital tooth. Radicular cyst, it is associated with non-vital tooth. So I hope majority of the options and the questions are completed in this session. Okay. Now I would like to tell you few important points which you have to remember in the coming NEET paper. Regarding the samematoid ossifying fibroma and ossifying fibroma. So samematoid matlab samoma-like bodies are seen, in which surrounding these samoma-like bodies, the fascicles or the whorls-like arrangement are seen, in which the collagen are intervened, in which collagen was intervened. While in normal ossifying fibroma, there is no whorls or whorls-like pattern or the collagen is seen. It is very thin. Okay, it is very thin. While samematoid, it has a thick and irregular whorls patterns are seen with respect to samematoid ossifying fibroma. Okay. So this finishes your November INI recall. I wish you all very best of luck, and I would suggest that start preparing or start revising your subjects. Start revising your subjects, because this is the month of November and you have exam on February. Okay, you have exam on February, so you have almost 3 months. Okay, and these 3 months, okay, are very crucial. So just start your revision without thinking here and there. And if you have not started your preparation, then I would suggest take crash course and TND. Take crash course and TND, which is very important at this point of time. So I wish you all the best of luck.